Live. Good morning, everyone, and welcome to a new appointment of the ISCAS and ICC Live Talk. These are events promoted by the International Coronary Congress and the International Society of Coronary Surgeons to enhance, promote the culture around coronary surgeon around the world. As the leading founder, Dr. John Pascas and Dr. David Taggart of the ICC and ISCAS, the concept was clear, not only offering a society that can organize a meeting once per year talking about coronaries, but rather instead promote culture with monthly appointment when we can discuss around major theme in the coronary surgery field. Everyone who is watching via the different social media platform can interact with us, can ask us questions, can see what we think, and all of these videos are stored in forever in YouTube as well as in the ISCAS website. And you can join and you can explore the ISCAS website, join the society, come with us and check all of the previous webinars where we have talked about fame-free trial, we have talked about CABG in women, and a lot of other important topics. Today, I'm here with an incredible team and group of prominent and very renowned coronary surgeons around the world. Unfortunately, we are missing, and we are hoping that Dr. Rashmi Yadav from the Royal Brampton Hospital will join us very soon. We have Dr. Faisal Bakin, professor at Cleveland Clinic, Dr. Joseph Savic, chairman of surgery at UH Cleveland Medical Center, Dr. Hiroshi Ninami, professor at Tokyo Women's Medical University, Dr. Stephen Frames, professor at Sunnybrook Health Science Center in Toronto, Canada, Professor James Tatulis from University of Melbourne, Australia, Dr. John Pascas, professor at Mount Sinai Hospital, and Dr. David Taggart from University of Oxford that has always been here. I'm Gianluca Torregrossa from Lankenau Heart Institute in Philadelphia, and we will start immediately today talking about my favorite second arterial conduit. And here we are. The way in which today we wanted to start this conversation is try to bring you back to you some direct feedback from the expert. So the concept again is learning something on a weekend that you can apply on your Monday morning case. And I create two cases that I have done in the last couple of months, and I want to hear from the expert what they would have done. So let me run these cases right now, and we can start to hear from all of the experts how they would have deployed their conduit. Here, first case. So he's a 58 years old, and I see him in the hospital. He's actually a very active guy. He's vice president of sale for the Southeast Asia market for an important pharmaceutical company that is based here in Philadelphia. He was in Tokyo, and on the way back from his last trip, he has chest pain in the airport, and he decided to go to his cardiologist. He has hypertension, diabetes, his HbA1c is 6.7. He's a tall guy, 180 centimeter, 5'10", and his weight is 93. So his BMI is 28, he's slim, he's not obese. He has family history. He smoked until 2022 when he had two stents placed in the ramus and in the right coronary artery. And now he has some epigastric pain, and when he was coming back on the flight, moving the suitcases in the Philadelphia airport, he had chest pain. The left heart cath, he was admitted. He has a small troponin leak, so what's called as a non-ST elevation MI. And the left heart cath showed 80% LAD, 90% of the first diagonal, 90% of the ramus, and 80% of the RCA. Normal function, normal heart. And here is the first picture. Injection via the left main. You can see the LAD the diagonal up here. Let me take the pointer here. Diagonal here. Ramus is here with the previous stent. And then there is a distal circumflex that does not have any disease. Second view, beautiful LAD, very important target, very tight lesion proximally. This is a good case for a coronary bypass grafting. Again, LAD, and up you can see the ramus and the diagonal coming up. And then an important RCA with a stent in the mid here. You can see the stent previously placed and the lesion all in the proximal portion with 2 grafts. So diabetics, normal function, non-ST elevation MI, beautiful targets. Cardiologists call me after the diagnostic cath and says, I think he will do better with, a bypass. And I agree with that. And I think we all agreed with that. So we start with Dr. Sabik. Dr. Sabik, tell me how would you deploy your graft for this patient?
Thanks. We got a young guy with severe disease in all his coronary arteries. This is someone I'd love to do all arterial grafting in. Obviously, I'd put his left internal thoracic artery to the LAD, and I plan on using the non-dominant radial as well as the right internal mammary. I know he's a diabetic, but he's not particularly overweight. Ideally, what I'd like to do is use the right internal thoracic artery as an in situ graft to the distal right, just before the bifurcation, just distal to that stent, and then use the radial as a sequential graft to the diagonal and that ramus intermedius and take it off the aorta. You may deploy the radial and the rema a little bit differently, depending when you get there, but that's how my plan.
Dr. Taggart.
So as you said, Gianluca, thank you. I mean, there's 100 ways to skin a cat, so that I don't think there's any definite right or wrong answer. I agree with the comments of Joe. This is a young guy. He's got diabetes, so we know that prognostically over the next 20 years, he's better to get as many arterial grafts as possible. I would do it slightly differently, actually, and this is just my personal view. I would do 3 distal anastomoses on the left side using 2 skeletonized mammary arteries, one of them being in situ. And I would then, because there's a very severe stenosis in that distal right, beyond the stent, I would put the radial artery to the right in this man. But that's simply because I think the severity of the stenosis means that a radial artery in that position should do well.
Excellent. Dr. Tatulis, tell us what would you do? Tell me double radial, please.
Perhaps not this guy. I did lever to the LAD and in situ skeletonized Rita through the transverse sinus to the ramus and a radial to the distal right coronary or PDA. I'm not sure that an in situ Rita would reach down there comfortably, so I would certainly use that to the circumflex and a radial to the distal right coronary or posterior descending. I'm not so sure about that first diagonal. I think it's a bit disease distally. I wouldn't fuss about it too much. If it was better than I thought, then I might use another segment of radial.
Excellent. Faisal.
Yeah, I'd probably do it like Joe suggested. Beyond that stent in the right coronary actually was not calcified based on the cath. And I think the Rita skeletonized would reach beyond that stent. Having said that, if the Rita doesn't reach, I wouldn't hesitate to take it as a free graft off the hood of the radial that goes sequential to the ramus and diagonal. And I agree with James, that diagonal is kind of small, and even the ramus looks bigger on the magnified views, but if you see it in other views, it's not that important. I think the right coronary system would be my next important target after the LAD, and that's why I would choose the Rita to the right.
Very interesting. Hiro.
Yeah, I use my routine way is using the or in situ arterial graft, of course the skeletonized way, because this is 58 years old. So I use a right mammary to the LAD, which is quite different from you guys, and then in situ Lita to the ramus and diagonal, and then GA to the PDA. That's my way. But depend on the size of the GA. If I normally just cut this very small incision to the tummy and to identify the GA is good enough to use the graft. If it's not, then I might use the radial. But normally I use the in situ GA for this because the stenosis of the right is quite tight.
Yeah.
So I think it's okay to use.
Can I interject and ask Hiro, is there a weight cutoff? I mean, we're talking about North American population. They're 200 pounds plus usually. Is there a weight cutoff where you hesitate to harvest and use the gastroeploic?
Let's say 180 centimeter and then 93 must be okay. But if the patient is over like 100 kilogram, then I may not to use it because it's too much fat in the tummy. So,
Yeah.
but fortunately, we don't have those patients except the sumo wrestler.
Sumo wrestler, yeah.
We'll
Dr.
have a special
Frames.
session for sumo wrestler called Cabbage.
That's another appointment, guys. Dr. Frames, how are you?
Yeah, good.
Tell us your strategy.
Yeah, what I would do, I would either do as James did in terms of the IMAs, or as Hiroshi did in terms of the IMAs. I would put the two in situ IMAs to the left system. The intermediate vessel looks like it would be a good conduit for an in situ REMA. But if that's not if it doesn't reach, then I would use the REMA to the LAD and the LEMA to the intermediate. And I don't think the REMA would reach well to a good spot on the right coronary, although despite what my American colleagues think. And I think the radial will. So, and I think in this case, despite the fact that we usually want the radial to go to the left system, the right lesion looks quite tight. And I think it's more than 80%. I think it's a critical lesion. And so I think a radial will work.
Excellent.
As far as his diabetes is concerned, yeah, his HbA1c is up a bit, but he's in his 50s.
Yeah.
And his BMI isn't bad.
Dr. Pascas.
Good morning. I would pursue in this what has become my very standard operation, an all arterial, no aortic touch approach off pump. In this case, with that right coronary, which I agree is certainly tight enough to support an arterial graft, I would likely elongate the skeletonized in situ right mammary with a very short segment of left radial in an I graft, expanded or extended graft, to comfortably reach the distal right or proximal PDA. I think it's very important that when we deploy the in situ right mammary, that it not be tight. I think that's one of the things that may have contributed to less than anticipated patencies for the right coronary. So a nice, generous, easy, zero tension right internal mammary with an extension of radial to the optimal spot on the right coronary. That might be just before the PDA, or it may be the PDA itself. The rest of that left radial would be sutured in a T-graft configuration to the side of the left internal mammary, and that radial artery side limb would revascularize the ramus intermedius, perhaps also the diagonal, although I was not impressed that was a good target. And the lead tip would be dedicated to the mid portion of the LAD, again with zero tension.
John, can I ask you quickly, how would you answer the fact that some people say that the patency rates of the radial artery when used as a composite graft are inferior to when you bring it off the aorta? Assuming you've checked your area of aorta is disease-free with an ultrasound probe, what's your feeling about that, please?
I've certainly done a very great many radial artery grafts from the aorta, many, many hundreds. But of course, that does require manipulation of the aorta. And I have found that this no aortic touch technique minimizes bleeding, minimizes stroke, and promotes an early recovery. We've had really beautiful patency rates from it. You know, the key to it, though, is the mammary arteries themselves must be atraumatically harvested. They cannot be spastic or injured because they are the sole inflow for the operation.
Thank
Love
you.
it. Thank you, everyone. As you can hear from everyone has a different, a little bit twist of how they would finalize this surgery, and that's why we are here. That's why we are discussing this topic, because there's not only one way to achieve our results. The concept, though, is try to promote a multi-arterial bypass grafting. I can tell you what I did. This was my case. So I offered him a Lima to LED, skeletonized, excellent flow. I think I had 80 millimeter per minute. I took the Rita and I passed through the transverse sinus, skeletonized Rita, but it ended up, the spot where I was landing with the Rita, I did all of this off pump. That's the way in which I like it. The way in which the area where I was landing was not the best area of the ramus. So I extended the Rita in a eye graft, exactly as Dr. Pascas was saying, with a piece of radial, short piece of radial, transverse sinus, and I ended up on the ramus. And this is because I really read a lot about the Dr. Bakin Faisal graft of how to dedicate a two mammary artery to the two most important target on the left side. Then I took a vein for the PDA, and here I could have used, as Hiro said, maybe a GIA, but I use a vein to the PDA, and then I use on the hood of the vein of the PDA. The vein of the PDA started from the aorta. On the hood, I attached the remnants of the radial that went to that diagonal. I can tell you that the flow of the Rita extended to the ramus was excellent. It was around 50 or 60. Lima to LED, I told you 80. The PDA to the vein to the PDA, again, excellent flow, around 70 or 80, but the flow to the diagonal was okay-ish, around 20, 22. And I think that a lot of you have pointed out that probably this diagonal was not as good as it looked. I could have even skipped it and just leave that massive LED alone and maybe try to use that radial for the right and give free arteries for the right. So this is what I did. This is real life, but it's nice to discuss. Second case, and then we continue a little bit.
Gianluca, just one quick clarification, if I may, because you cited my paper.
Please.
And the work was agnostic. The conclusions was the importance of the vessel is agnostic to the left or right side. And that's why in this particular case, I thought that the right was the second most important target and not the ramus.
Yeah. Thank you. No, in fact, after listening to all of you, effectively, maybe I should have put an arterial graft to the right and not go after the diagonal. You know, that's something that sometimes we are shifting in this culture of from Cabs times 11 in the past seems to be you go after every target to less distals but more arterial graft. That's a little bit of the concept of the distal that really count.
So Gianluca, this is for you and John. In terms of eye grafts, and this is for the community, when you do the eye graft, you use the very terminal portion of the rima to do the anastomosis, or do you chop off the terminal portion of the rima and do it in a larger portion and use more radial?
Tend to do the latter, Jim. And it's a generous, so take off the distal portion that's maybe a centimeter or a centimeter and a half that tends to be more spastic. This is assuming we have adequate length of conduits in general for the desired targets. But generally that would be a slightly trimmed distal mammary with a generous spatulation of both conduits. I construct that anastomosis up on the drapes. It is a absolutely immobile, perfectly visualized, well illuminated anastomosis that is not moving at all. It's a set piece. It's a standard sequence of sutures. We literally count them out as we do it. It is done exactly the same way every single time. And of course, we test the flow in that and in the T graft that we put on the lateral side of the left mammary before beginning any distal anastomoses. And all of those composite conduits are constructed after administration of systemic heparin.
Can I ask a quick question? So, one of the things I'm thinking is, obviously it's important to be extremely flexible, in what we do. We go in with a plan and sometimes we get there, the diagonal's not right. And so we may change. But the one thing that I'm hearing a little bit and I think where maybe Faisal and I differ from some other people, is the on pumpers versus the off pumpers, and that you're doing things because you can't quite reach. And you obviously have a lot more experience with off pump than I do, but are you having to make conduit decisions and extension decisions because you're doing surgery off pump? And if a 58-year-old guy without really any other reason, do you think there's benefit of off pump in this guy? And do you think some of the in my mind, compromises to conduits that you're making may affect the long-term outcomes by doing it off pump? That's the one
Joe,
thing.
if I can make a quick comment to that, please. I think it works in both directions. So I think when you do things on pump with the heart completely collapsed and empty, everything's technically easier. And then you come off pump and the heart fills, and then you can wonder, does that graft look a bit stretched? Whereas when you're doing them off pump, you've got a real live situation of the length of your conduits. So while I get the point you're making, I think it can work in reverse. I think you can do them on pump with everything collapsed and everything looks right, but you come off pump, the heart fills, dilates, and suddenly your graft doesn't look quite as good as you thought.
Yeah, and I think that's where the important roles of intraoperative assessment of your graft come in. I know,
Yes.
I completely agree. I think that, it's one of the things that I just enjoy mostly about coronary surgery is this mind game that we're playing now. Everybody's presented wonderful options, and it's great to learn from each other. But it's also, I think, important being very flexible when you go in the operating room. We have a plan, but we often change it a little bit because we tailor the operation to the patient. That was just my question. I'm just wondering how much tailoring, goes on because it's off pump versus on pump. That's all.
I think those are great considerations, Joe. I think it's very important that we do exactly the same degree of revascularization off pump as we do on pump. I don't think that for many patients, and probably not for a 58-year-old with few comorbidities, would it be a good trade-off to do fewer grafts, for instance, of meaningful targets in order to accomplish an off-pump operation instead of an on-pump operation. I think that would be a bad trade-off for this patient. But in general, I would say we don't do that. I like the grafts to be never tight. I think this is an important concept. I think especially in situ arterial grafting, if it seems to you that it might be tight, it's tight.
Completely agree.
Redo it, extend it, do something else.
Yeah,
I think that's an important. Closing the chest and saying, "Oh, it'll be okay because now the sternum is closer together." No, I don't do that.
Leave unhappy, come back unhappy.
Yeah, the grafts are slack. They're not redundant and kinked, but they're slack, and they should be, I think, to achieve the optimal flow. And I certainly would echo what you've said, that intraoperative graft assessment is a must. Especially if you're hanging everything on two mammary arteries to achieve a no aortic touch, all arterial operation. You better be darn sure those two mammaries are working.
Yeah. Excellent. Dr. Pascas, I learned from you the extension, and I love to do it, particularly because then a lot of time I do RIMA extended radial, and I do multiple graft all around to do an aortic type of techniques. I tend to do not give full heparinization recently. I give 5,000 or like 8,000 units of heparin, and I do all of it. I don't know. I'm not really good. It's not that I'm scared about bleeding. Technically, potentially, I should just give a full heparinization. But I've always, I've recently just give 8,000 units of heparin. I give 2,000 units when we start to take down the conduits, radial vein, and then I give other 5,000. So when we are preparing the eye conduit. I don't have any data to say that this is good or is a good practice. Maybe I should not do it, but that's what I do.
Gianluca, I think the other important comment is what Ki-Bong Kim from Korea has taught us. If you look at his angiographic patency data for arterial grafts extended by a piece of vein, they're absolutely outstanding. Now, most of us before 5 years ago, I would have found this quite difficult to believe it's as good as a second or an extension with an arterial graft. But the data from Ki-Bong Kim shows that if you need to extend and you don't have an easy bit of artery to use, don't hesitate to use a bit of vein.
How many of you would use it? And it's interesting because we just got a question from the audience here. We have Dr. Reddy telling us if RIMA is not reaching the ramus, it's a good extend RIMA using vein or other arterial conduit. How many of you would or use in the regular practice a vein extended erita or erita extended with a vein? Dr. Sebik, yes or no?
No, I again, I don't do a lot of eye grafts. I would actually change my graft configuration and maybe do it differently.
Dr. Taggart, do you use it? Would
So
you use it?
in the last few years, I've changed considerably. I think the data from Ki-Bong Kim is so compelling, and it's also technically very easy to do, and it also allows you to avoid any aortic manipulation. So in the last few years, I've changed my concept about this.
Dr. Tatulis?
A free graft.
Free graft. So you would put it to the vein from the aorta. Faisal?
No, I'll put the free Rita directly from the aorta.
Sorry. Even better,
like
yes.
a vein graft.
I see. Dr. Bakin, Faisal?
Yeah, a free graft and take it off the hood of the radial. But I do use veins occasionally. If I don't have arterial extensions, I can use a vein, but the vein has to be nice, soft, and pliable.
Yeah, but this is a real world. Sometimes we have been there, done that. Sometimes you have this. Even with your best PA who takes the best vein, sometimes you take out this stuff that you spend more time fixing them with 7.0 than anything else. And I'm sure it happened to all of us, guys. So when you are there, Hiro. Have you ever used a vein extended, Rita? A lot of vein.
I use the vein to the right mammary eye extension, but very rare. If I don't have any solution, and if I don't want to touch the aorta, in that case.
Dr. Frames.
Yeah, in this patient, for that patient, I would use a RIMA as a free graft, and usually put it on the hood of a vein as opposed to a hood of a radial. But use vein extensions as a bailout, not as a preferred procedure.
Dr. Pascas, you use it.
We have, and it typically, our baseline operation is double mammary left radial. This is the standard routine operation. If the radial artery cannot be harvested for whatever reason, it's been cathed 6 times, or it's occluded, or there's arm ischemia, then I have, and I would in this case, for instance, harvest both the mammaries and take one piece of vein. The right mammary would be disconnected from the right subclavian and leave a short stump. On the end of that stump, I would take the vein and do the spatulated anastomosis for the vein. So the Rita would provide inflow to the vein, which would go to the distal right. The Rita would come off the side of the Lita and give me 2 arterial grafts to the left system. Yeah. And I would keep my fingers crossed that I can replicate the same great outcomes with veins off radials that Ki-Bong Kim has done, and hope that that vein will behave like a radial to the distal right. But I would give that patient 2 arterial grafts to the left and stick to the no aortic touch strategy for him overall.
Cool. Very interesting. Very, very interesting.
So John,
we did exactly that operation last week. I mean, it's real life.
You mentioned that if the radial was cathed 6 times, does this mean that you would use it if it was cathed 5 times? And I'm just being facetious, really, because some people say that even if it's cathed once, you shouldn't be using it. Some would wait 2 months. Some would say never. What's your practice?
I think this is a great topic of conversation, and thank you for bringing that up, Faisal, because I think we all scratch our heads on this at least once a week. We will do, of course, a pulse oximetry Allen's test, baseline routine visual Allen's test, a pulse oximetry Allen's test, and then we'll take the ultrasound probe and we'll scan the arm. Mm-hmm. If the vessel shows, if you're looking at the interior of the vessel, you see webs and strands of fibrous tissue and scar. No. And I confess, sometimes we've harvested those and examined them and discovered we wasted our time harvesting. If the patient had a cath last week for the first time via the radial artery, I would usually harvest the other one
Yeah. I mean, the good thing is they usually use the right radial to do the cath. At least that's my
one of those
experience. Usually
circumstances
they
where the
leave the left
cardiologists
one.
go right and the surgeons go left. It's not a political statement, but it's helpful.
Yeah, at least that's in my
It's
experience.
helpful for primary cabbages, not redos, unfortunately.
Yeah.
But yeah,
Faisal,
my
we
practice is
published a
like
review
yours.
in Circulation that showed very clearly if you use a catheterized radial artery within 3 months of the catheterization, there's a much higher rate of occlusion. By the time you get out to a year, the evidence then isn't so clear, but then there's not so much data either. But I think as a general rule of thumb, if you have a radial artery that's been catheterized within the last 3 months, don't use it and especially not for an important bypass graft.
So David, I use a hybrid between your answer and John's answer. I wait 90 days and then I use imaging to guide me.
You use which images? What do you do?
Well, we do ultrasound, and I actually look at the vessel from beginning to end, looking for intimal irregularities, webs, etc.
And if you see something, you discard that portion or you discard the entire conduit?
Well, it depends. If it's proximal or distal, you can cut it off. But if it's right in the middle, maybe you shouldn't use it.
Yeah. Is exactly what I do, Faisal. I have exactly your strategy. Ultrasounds, I don't do the Allen test like I do a proper Allen test in the OR. Actually, I don't do it. I have three phenomenal PAs that they do it. And with ultrasounds, they can, and they tell me exactly where was the puncture, can we exclude it, how long more or less the conduit will be, how does the rest of the conduit look like. And if we have, if it doesn't look good, we don't take it. And even with this tight regimen, we still use a lot of radials because I think it's worth it. But I agree, there is some concern of taking out a radial that has been recently cast.
I think it's worth trying to educate the cardiologist in your institution to please go to the right. It makes a difference for us.
I agree, completely agree. And in fact, here we have some Gustavo who is giving us his feedback. In his hospital, unfortunately, a lot of left cath from the left radial. And I believe, I'm not an interventional cardiologist, and maybe some interventional cardiologists watching us, a lot of time they prefer the left because there is less variability. From the right, you can have abnormalities or it's difficult the angle to reach. And sometimes from the left is a little bit more, it looks like more a femoral artery for the way in which they do the cath. So a lot of people that don't feel super comfortable with the radial cath, they tend to prefer the left. It's easier than going from the right. That's one of the things that some of the interventional cardiologist friends of mine told me, but I'm very happy to be educated by a proper interventional cardiologist about it.
You know, I don't think it makes any difference whether you're harvesting the right or left radial, or for that matter, the right or left mammary, but we don't want them to cath one and then the other. Pick one and stick to it.
So actually, a common trend in with cardiologists who are doing CTO procedures in young, healthy people is to go biradial as opposed to bifemoral. And
that is satanic.
That is satanic.
I'm saying it is a common practice now.
Rajmi, welcome on board.
Hi, I'm ever so sorry to have missed this beginning of the session. My apologies. Delighted to be here. It's a huge honor.
This is you're a surgeon. We are always, this is a real life Saturday morning, so sometimes it doesn't work and there is a lot of things that happen. So don't be worried. We have still one more case to discuss.
Fantastic.
But for now, I want to switch a couple of gears from the radial, and we will give Dr. Tatoulis to give us a presentation about the radial. But let's focus a few minutes about GIA. I've always been fascinated by the GIA. When I was in Tokyo for the ICC last year, I went a couple of days earlier, and I had a great pleasure to scrub with Hiro, with Professor Ninami in his institution, seeing how beautifully he does his beta. Was a beta case with a GIA, how much he investigate even pre-op the GIA. And, you know, coming from Europe and US training, I've never been exposed to a GIA. I don't even know how to make an incision below the diaphragm. I don't know anything below the diaphragm. I'm a doctor between the neck and the diaphragm. I don't know anything else. So, Hiro, I'm putting up your slides that you share with me and your video. Here. Go for it. Tell us a little bit about your GIA, where it comes out, how you do it, where is it?
Yes. We normally check by the angio or the CT, the quality of the GA. And this patient GA, the video is not very well.
Yeah, I'm trying to wait a few seconds to see if it can load a little bit.
Okay. This is actually this GA was the biggest GA which I've ever harvested. This was just 1 month ago. It's a big one. It's like a saphenous vein. So I use a harmonic scalpel to harvest it, and then this is a not like the harmonic for ITA. It's a scissors type. So this is a usual. I mean, the skeletonized, but I say super skeletonized. I will show you later why the super skeletonized. This is just the skeletonized way. Then, after harvested, then I clean up all the surrounding tissue.
Oh.
Takes a little bit more time, but why I do this is because I eliminate all the periarterial nerve to avoid the spasm of the GA, because this GA is more prone to spasm compared to ITA. That's why. And then some data showed. Also, we also check the histology, comparing the non-skeletonized GA and the skeletonized GA, and there is a big the nerve in the surrounding tissue. So this takes a little bit time, but it's nice and non spastic. And also I also always close the omentum.
Yeah,
So
that was the closure of the omentum. Fantastic. And when I was in your institution, you showed me even pre-op, you investigate the GIA with a direct, so your interventional cardiologist at the time of the diagnostic test. What does he do? Tell me.
My cardiologist, my team in the institute, they prefer to use they not hesitate to do the pre-op angio at the time of if the patient with severe triple vessel disease, because my previous boss, the Professor Endo, started using this the graft very aggressively. So the team is already trained to do the angio of the GA, and then if we have that kind of information, it's easy to make the plan beforehand. So that's one of the good things for us, but not always, because I get the referral from the outside of our hospitals. So in that case, if I have time and if the patient renal function is okay, I ask the cardiologist to check by the CT or the angio. But if the creatinine is not good, then we just open the tummy like a couple of centimeters and then check the eye and then the palpation. Then decide we can use it or not. If the size is like a less than 2 millimeter, then if the quality is good, but I still don't use it because the flow is the GA is compared to the ITA less, because the third branch compared to the ITA is the second branch. Yeah. So there's some, the tricks. But
so you said if the patient has more than 100 kilos in general, like a big BMI, you tend to stay away from the belly, correct? Because there's too much fat.
Yeah, that's because if the fat is too much, it's not so easy to take down. Yeah. So and we have to open the tummy much more.
Yeah.
So in that case, but if the patient is very young, like a 40s, if the patient is very fat, but I use it.
I love it. Who else? Rajmi, have you ever harvested a GIA in your career? Tell us. You are muted, and I unmute you right now. No, you have to unmute yourself.
Thank you. Just like you, I'm also a surgeon between the neck and the diaphragm. So I'm afraid I've never harvested a gastroepiploic, so I couldn't really contribute to that discussion, but really credit to the people who do it. One interesting point is when I do my radial grafting, I open the fascia on both sides. And that is to try and remove as much potential for vasospasm. So I don't know if other people do it, but I do open the fascia one side, turn it over, completely clean it also on the other side. So I noticed that there is some similarity in the technique of an artery predisposed to spasm. Perhaps Dr. Tatulis would like to.
Yeah, we have here the presentation of Dr. Tatulis. And Dr. Tatulis, please give us your presentation of how you prepare your radial. You have been extremely proficient in radial artery. You published so much. You contribute with randomized clinical trials. So tell us a little bit about your radial experience.
Well, firstly, the radial artery is much larger, much more robust than the mammary, as you can sort of see there. So it's much easier to use, although we do use both. Next slide. And as I was just said, it's a very supple artery, and we do open the fascia on both sides. Next slide. And it's a lovely artery to use, actually. Occasionally there's some calcification, but we use it in about 95% of patients. Next. And distally, when you splay it out, it's at least 5 or 6 millimeters, so it's as large as a vein graft generally, but obviously we avoid small arteries, less than 2 millimeters, and also with this going to be competitive flow, and we strongly believe in spasm prophylaxis. Next. It's a good size match. That's why we use it for the circumflex or for the posterior descending. Next. So here we are with the circumflex marginal, and because of its robust nature and slightly thicker wall, it sits nicely. So it's a very easy graft to sew onto the distals. Next. And proximally, we place it directly onto the aorta usually, and you can sort of see the proximal anastomosis is often about 7 or 8 or sometimes even 10 millimeters across with a lovely hood. Next. So this is deploying it to the posterior descending, and again, it's a really good size match, and because of the nature of its wall, it stays open, and it's very easy to use. Next. And here we are completing that anastomosis. So you can sort of see its stronger wall allows it to stay there and be an easy target to line up to construct a nice anastomosis. Next. So that it is approximately. Can you run that? That should run as a video.
Let me see. Oh, no, cannot play media. Yeah, I probably have a problem with the file.
Okay, all right. Next one. So here's the radial that's been placed directly onto the aorta, going to the posterior descending, and sometimes can even reach the posterolateral branch on the right side. So we often use it there if the right coronary artery is blocked or tightly stenosed. Next. It's terrific for sequentials because the wall allows it to sort of pout there, and the large size. Next. The large size ensures that you never get a seagull effect, and we tend to run it in a parallel way if we can, but not necessarily. You can sort of see again, it's very facile to construct the anastomoses. Next. If sequentials are not possible, then a short segment of radials we're talking about before is terrific for a lateral or high diagonal or a parallel diagonal. So these baby Y grafts are very, very useful to overcome problems with lie. Next. And the same with the circumflex. Sometimes the sequential on the circumflex does not go to the best places on the marginals. So this way you can choose the most ideal locations for the anastomoses. Next. and then the proximal anastomosis is pretty easy to do just by incising the base radial and then sewing end to side to the main trunk. Again, it's a very straightforward anastomosis. And lastly, there it is there. And lastly, we do use it on the next slide to reach further on the right side. So here's the posterior descending main graft on the left side, and a baby Y graft going down to the posterolateral branch. So that way we've achieved the total arterial revascularization. And we often use bilateral radials in about 25% of cases and use the left radial almost routinely. Thank you. Having said that, I do use two mammaries in patients less than 70, either as an in situ graft to the proximal circumflex or as a free graft to the mid circumflex, and occasionally as a Y graft to the distal circumflex.
Interesting. So Rashmi, tell us a little bit, what is your strategy? I love what you were saying about opening the fascia both sides, left radial, right radial, and what is your, if the patient had a previous cath, do you use it? What is your recipe there? Do you wait sometimes? Do you do ultrasounds?
So you asked lots of very interesting questions. So strategy generally is radial artery to the circumflex. If it has sufficient stenosis in it, I wouldn't hesitate to use it for a sequential. As Professor Tulis says, it's really well suited to doing sequential graft to two parallel vessels. I've often also used the radial for a sequential to PDA to PLV. If the radial artery has been catheterized before, then I would wait 3 months, and I'm speaking with my cardiologist, making a request of them to use the dominant radial for the cath, although they say it's quite difficult for them to use the left radial ergonomically. And your other question was about
fascia.
Sorry.
Do you open the fascia? You said you open the fascia
so,
bilaterally. Your connection is a little bit delayed.
What strategy? So we've talked about the strategy, and we've talked about whether if it has been used in a catheterization recently, then I would tend not to use it. Yes, right or left radial. So I wouldn't hesitate at all to use a right radial in a left dominant circulation. So
Rashmi, I cannot hear you very well.
Yes,
there is a lot of
fascia, but that was also, you asked whether I use the right or the left radial. Is that what you were asking?
Yeah.
And dominance.
Yeah, Rashmi, I cannot hear you very well. There is a lot of delay. Sorry for that. But how many of you guys use a right radial? Like, how many of you tend to use a right?
Well,
Dr. Tulis,
what I was saying
right?
is that if the patient is left-hand dominant, I wouldn't hesitate to use a right radial.
I see. Faisal, what is your taking on from there? Do you use a right radial or no?
Well, take home. Well, sparingly. I mean, for reoperations, I do. Obviously, when I have shortage of conduits, I do. Yes.
Hero, right radial.
Depends on which is dominant. Mostly the Japanese people are the right dominant, so I prefer to use the left. But only 5% I use radial.
That was Civic.
Well, you know, obviously taking the left radial works very nice if you're taking the left mammary, but you know, sometimes the patient, you know, may be left-handed, so you may want to use the right. But having said that, I don't pay too much attention to the dominance anymore, but try to just use whatever kind of works with the operation that we're doing, so it's the flow keeps up.
I would agree with Joe. I don't think it makes a difference in terms of dominance. I mean, when the team has real experience in endoscopic harvest, I think the risk to the limb approaches zero. I mean, we have harvested thousands and never had a major vascular problem with the limb. Occasionally a little thenar eminence numbness, I think from that superficial cutaneous nerve that can sometimes be damaged. But radial harvest endoscopically is so benign that I don't even give a consideration to the dominance. I want the best radial removed from that patient.
Yeah. Let me
I do think it's important to split the fascia. And I think Dr. Tutulis has taught us the importance of pharmacologic prophylaxis against radial artery spasm. And I'll also say that I have borrowed Dr. Tutulis's baby Y technique extensively. I like it rather than doing sequentials, which I think have a greater risk of a problem in the first anastomosis that impacts flow to the second vessel. So I think the baby Y constructed before connection to a mammary inflow or to aortic inflow is a great technique. The measurement of it is unforgiving. You've got to be sure you've measured twice, cut once, and then sew the pieces together and get it right. That's very important.
So I need advice from the panel because I am unclear on one thing. You know, when I was part of the VA radial study, I never opened the fascia on any single graft. And I contributed 42 patients to that study, and I had no problems, no string signs. And believe it or not, the grafts were open, and I was really impressed. Then I went to the Cleveland Clinic, and Gus Paris said, you got to open the fascia, you got to open the fascia to prevent a string sign, and you get better patency. So I started opening the fascia, but then now I see Hiro, he's not opening the fascia on both sides. He's removing everything. I mean, it's as skeletonized as you're almost taking the adventitia off the gastroepiploic. Does that really make a difference? And sometimes when you take a skeletonized mammary in that very end portion, and you're trying to put your sutures in it, it spasms and closes on you without having periadventitial tissue. So does that aggressive fascia removal and skeletonization really make a difference in terms of spasm?
I think that's a great question, Faisal. I cut the fascia, I don't remove it. And I want to see a radial that has the vein on either side. It's a pedicled harvest of the radial artery, as atraumatic as possible. I think your concerns they resonate with me. I share those same concerns.
Yeah, but don't you think at least
that's one of the great things. I was going to say that's one of the great things about radials that because the wall's slightly thickened, the sutures are almost never ever cut out, unlike the distal IMA. So that's just another advantage.
Yeah. To me, it was kind of like the migration from a pedicled IMA to a skeletonized IMA. I don't know how people feel, but I actually find using a skeletonized conduit a lot easier to use and really see what I'm doing, and I'm really happy with that. And I agree. I don't necessarily take the vein out, but I open the fascia on the radials. We harvest it endoscopically, and being able to see the entire conduit, I think, is so beneficial. I got to tell you that GEA presentation, Hiro, was unbelievable. I've never seen a GEA like that, but I can see how beneficial that can be when you're using it. You see the entire conduit, you know it looks good. And there's a lot of benefits to seeing what you're doing.
I agree.
You have to see what you're doing, and he called it "love with the lights on."
One of the benefits to do the comparative scan, I mean the super skeletonized, is easy to check the quality and also easier to handle, and then do the more and more sequential. But we did the historical check, and then there's a big nerve. If you don't completely skeletonize, then that is the cause of the spasm. That's why, because Dr. Suma showed a 10 years result of his GEA was not good. because he didn't do the skeletonized way. Then we learned, and then we did we started the skeletonized way. But just the routine skeletonized way is not good enough. That's why I start doing the super skeletonized way. That's the reason.
I want to show this question because I love this provocative question from Luis Roberto Dallan. He's following us from University of São Paulo, Brazil. He contributed with some question before, but in one way it's true. Like, we are now promoting more no-touch vein. So we pass from, we take our vein and now we say, don't touch it too much. We said, let's skeletonize the memory, but now someone actually from Canada, I believe, recently published, and we discussed it here in our live talk. Even in the ITA, when you skeletonize, if you're not like, we could not be good. And now we are talking about super skeletonization. What should we tell to these guys that are following?
I think we have the
kind of
terminology
schizophrenic,
wrong.
to tell you honestly.
Go, Joe.
The terminology is wrong. It should be no trauma technique. We shouldn't traumatize the memory. We shouldn't traumatize the vein. We shouldn't traumatize the radial. We shouldn't traumatize. You can skeletonize it as long as you don't. I mean, how many of us, when we first started using skeletonized memories, we would see all of those, little dissections along every single branch because it was traumatized, because people took it down like they took down a pedicle graft. So we've had to change our technique. So I suggest we go from no touch to no trauma.
Yeah. I tell them harvest white noodles, not purple sausages.
Yeah.
I love noodles. You can say spaghetti. I mean, you are down my alley at that point.
Spaghetti, yeah.
And instead, and I love this one, but I want to one more question for everybody. Like, we are all here discussing how cool are the radial, memory. We are finding a lot of agreement among all of us about radial, Rita, where I use this, when I use that one, GIA, everybody interested. But there are two things that I want to discuss with all of you. First, I have noticed a little bit more in literature, almost a contrast, Rita radial, that I think instead should be promotion of multi-arterial. And second, despite we are all in agreement that using at least a second arterial conduit or a total arterial conduit is great, why we still have a use in the United States that overall is less than 10%, and in Europe that is not much better than that? We have investigated multi-arterial bypass grafting more than what we have investigated the benefit of repairing mitral valve in degenerative mitral valve disease. We have so much burden of data, and for sure we will need Roma, for sure we need a randomized control trial, but at the end, how much more evidence do we have? What can we do to change culture? Why the STS does not acknowledge even the use of a second arterial conduit in their own standard quality metric of care? How we should use our magic wand to change the culture towards more arterial conduit? Dr. Sebic, let's go around and let's try to have the input of everyone.
Absolutely fantastic question. I think there's a lot of reasons. I think, first of all, as surgeons, we've become too survival focused and not outcome focused. And I think we do debate as to whether we can prolong survival, but we know that outcomes are better. Less angina, less myocardial infarctions, less repeat reinterventions, when you use multiple arterial grafting. I think that's, one part of it. I think the second part is it's more difficult. Let's be honest. Doing multiple arterial grafting is more difficult than an IMA in vein. And I think we need to be dedicated, as surgeons, to learn these techniques. And then third, I'm a big fan of coronary specialists. A lot of places look at the coronary as the operation you do at the end of the day after you've done your mitral valve repair or your David or whatever. It amazes me that the most common operation we do, which is coronary surgery, is not looked at like mitral valve repair or aortic repair. You go to our meetings, you would think 80% of what we do.
What happened? Dr. Sebic, we lost you.
Yeah.
David, Dr. Taggart, tell us your input.
So thank you, Gianluca. A great question, as Joe said, and I can't really add much to what Joe did say. But I would say one of the major failings has been the leadership from the societies, not just in North America, but in Europe and Asia, to start promoting as a quality index the use of a second arterial graft. And you don't need to make it revolutionary. You could say that a standard for each unit would be to have at least 20% of patients undergoing coronary surgery getting 2 arterial grafts. And 5 years later, say it should be 30%. Because by when people start learning, it'll probably reach its own momentum anyway. But without the leadership from the societies, we're not going to get anywhere. And if you look at the ART trial, which people said that it showed no benefit of a second arterial graft, well, it did. If you looked at the as treated analysis, there was a very significant benefit at 10-year survival in the patients who actually got 2 arterial grafts versus the numerous patients who were randomized and didn't get the randomization. So I think if you look at the biological plausibility of arterial grafts in terms of their proven patency at 10 years, there's a very striking difference between arteries and veins. Although saying that, with the data that Ki-Bong Kim now produces, that gap may be lessening.
Love it. Very, very good. Hiro, give us your view. How can we promote multi-arterial? What should we do?
It's quite different from the Japanese society and the Western country society, quite different. The coronary surgery in Japan is already subspecialized. So because the number of the coronary cases is much, much less compared to the Western country. So that's why in Japan, the bilateral mammary usage in the average whole Japan is about more than 30%, close to 40%. So, but in the United States or other Western countries, the coronary surgery is kind of the general cardiac surgery. That's a major difference. So I think the coronary surgery is like aortic surgery, the mitral surgery, it's all specialized. The coronary surgery should be subspecialized. That's the way. Then we should think about it. It's not easy operation, but that's why the easy operation is using just 1 liter to LAD and the vein to the other remaining the target vessel and then on pump. But the patients more and more comorbidities, so it's changing. So we should think about it should be subspecialized. That's my opinion.
Dr. Frames.
Yeah, it's a great question. Certainly, there's a lot of publications that support it. I think the best way to change is through training, through the residents that come through the programs. And if they receive training in arterial revascularization, whether it's total or partial, they'll adopt it, and there'll be a gradual adoption of the techniques in the greater community over time.
Dr. Tatulis.
Thank you. I think it's because the training is too insular in many jurisdictions. People train in one institution, they never see something different, and so they never do anything different. So I think the only way you can change it is by having people train in 2 or 3 different institutions and be exposed to it. So I think that's the way to go. And that's what we do. Our trainees must go to 3 different institutions.
Faisal, gives your input.
Well, like David said, I mean, if you look at the literature, if you look at the as-treated analysis of ARTS, the hazard ratio was 0.8 when used multi-arterial grafting. And if you look at registry data, like the Joe Wu study from California using the state database and the Joe Shikwe from New Jersey, the hazard ratio for survival for multi-arterial versus just a single mammary and vein also is identical to that of ART as-treated analysis of 0.8. So there's a signal there. But the surgeons are quite specific by saying that there is no randomized evidence to support that. And I agree with them, especially when there is a penalty. So you mentioned that the STS does not reward you for using bilateral mammary. Even worse, if you do get mediastinitis or sternal wound complications, you get penalized. Then you get a look at the financial penalty. I think it adds half an hour to an hour to do multi-arterial or all-arterial grafting. Who's paying for that? Yeah. And then you look at the boards, the requirement for the American Board of Thoracic Surgery. There's not a single requirement for bilateral mammary or skeletonized harvesting or bilateral mammary use, or radial for that matter. So our graduates are not familiar, and they go into what Joe Sabik said, the survival mode, rather than anything else. And then finally, if you want to do it well, you got to train yourself. Like you said, like you did yourself, Gianluca, go to centers of excellence, train yourself, and incrementally implement that in your practice. But never, ever do multi-arterial grafting for sure. If you're inexperienced, uncomfortable, don't screw up the operation. Do the safest operation that you could possibly do.
Dr. Pascas, you're muted, huh? Make sure you're unmuted. I think you have to unmute yourself.
Thank you. I think the evidence for multi-arterial grafting is very strong. Just as Faisal commented and summarized very nicely, the easiest way to get from the traditional conventional operation of a single mammary and veins to multi-arterial grafting is to hire a PA who can harvest a radial artery well. And then use the radial artery as if it were a vein on your second most important target that has a decent, fairly tight stenosis. If the whole world, if the community of coronary surgeons in general simply did that, we would provide a much better service to our species, who is most likely to die of coronary disease rather than any other disease. So this is the surgical therapy for the disease that kills most of us. We ought to try to do it as well as we can. And the easiest step forward for the whole community of surgeons is to add a second arterial graft in the form of a radial artery. Use it whether on pump or off pump within your comfort zone to graft the second most important artery. I do think that we should ask and expect that our surgical societies will lead rather than follow surgical trends. And I do think that all of our national and international organizations should advocate for a second arterial graft as a quality metric, and payers, whether they're federal or state or private insurers, should reward the surgeon for that extra effort. I do agree with Joe in so many things, that coronary surgery has become and should be recognized as a subspecialty. And frankly, I think that the International Society for Coronary Artery Surgery and the International Coronary Congress and some of the other coronary-specific meetings that have popped up since we founded that organization 9 years ago, I think those play an important role. So I think that what we're doing here today can make a difference to the field. And thank you all for participating.
I want to applaud John Pascas for an excellent summary recommendations.
That was fantastic, Dr. Pascas. Rajmi, all yours. The panel is yours.
Thank you. Everything has been said, but I'd like to start by saying, agreeing with Dr. Pascas, Professor Pascas's last comment. What we're doing here today, disseminating our practices and the research on the field in a very accessible way to a very large number of people will make a big difference. You know, people read publications, but this is so much more accessible, and people need to be convinced to take that extra pain on of doing the arterial grafts. So I think what you're doing, what you've organized with the ISCAS is fabulous. And I think the more we disseminate, the more we have these chats at the weekend over a coffee, the more people will be convinced to use this. And then I think making it a quality metric would be really helpful. Again, it's been mentioned already, when the Lima, 100% Lima use became a quality metric, Lima use came close to 100%, certainly in the UK. And I think we simply need to make a second arterial graft a quality metric. And surgeons don't like to underperform when there is a quality metric. I think that will definitely be a motivation. And I think the third most important thing is training and the confidence. And I have seen in my own self that, you know, as I have become a more experienced surgeon, I'm much more, let's say, stubborn. I'm going to do an arterial graft. I'm not going to give in to pressures about patient complications or theater time or any of those things. And I'm really committed to doing this. So training and experience will also make a difference.
Huge. Dr. Sabik, we have seen that you were dealing with a lot of technical difficulties. I think your microphone is off. I heard that there was a big storm in your area. Probably.
Was that the storm, or was that the STS sensors?
No, for
Guys,
some
just as
reason,
we wrap up,
I'm still on generator power. I'm losing my Wi-Fi.
as we wrap up, can we thank the panelists, the audience, and especially Gianluca Torregrossa for his time and effort in organizing
thanks,
these
Gianluca.
outstanding webinars. They're fantastic.
Thank you, everyone. And I just love to show some of the inputs here that we have from people. Gianluca Folesani is from Italy. He won the last STS Traveling Fellowship Award. He was in Philadelphia with Joe Bavaria and with us, learning about coronary of pump and robotic mitral and robotic coronary. And again, it's more point to the importance of the training, and it's lovely to see how many people are following us. Again, Alexander Docolari is my research fellow. This is like friends and family for me. But you know, it's beautiful to see how many are giving us input. We had people watching us from Jordan. Here, Nizar, thank you for watching from Jordan. Haiti, and I'm sure that for Nicodem, it's not easy to travel and come to Tokyo or to come to New York for the ICC. And we give an opportunity to countries where it's not easy, even economically, to travel around the world to improve the quality of what we do. And I want to thank everybody who was watching us, everybody who texted me, everybody who stopped texting me on my phone. I try to follow and reply to everybody. Special thanks to Dr. Tatulis and Hiro. It's 9 p.m. in Tokyo. It's midnight in Australia. I hope you guys are drinking your red wine or your whiskey when I'm at my coffee time.
Gianluca, it's 6 a.m. in California.
Oh, you are? Oh, I didn't know, Dr. Pascas. I could tell by your voice. I could tell by your voice that or you had a rough night, or you were not in New York City. That was. So, thank you, everybody. Really, thank you so much. Thank you, Dr.
Thank
Taggart.
you, Gianluca. Thank you, everyone.
For everything, and all the best. And come, stay connected with ISCAS and stay with us. This is
very well done, Gianluca. Thank you.
Thank you.
Yes.
Bye-bye.
Thank you very much.